My name is Alex Eddy, and I'd like to share with you a case study that I carried out with Dr. Shelby Brown and Dr. Chantre Dorset involving a gynecological patient. This case is titled Teeth and Hair and Sebum Oh My, a case of bilateral large ovarian teratomas. What is an ovarian teratoma? It's a germ cell tumor, and it can either be benign or malignant. If benign, it's typically referred to as a mature ovarian teratoma, and it comes with mature derivatives of ectoderm, mesoderm, and/or endoderm. If malignant, it's referred to as an immature teratoma. So the typical surgical patient presenting with an ovarian teratoma is a 33-year-old female who comes in with the chief complaint of abdominal pain. So this is yet another reason why it's important to do due diligence and an abdominal pain workup in a female, or anyone really. Ovarian teratomas are bilateral in 10 to 15% of cases, and a relatively common complication is ovarian torsion, which can occur in about 5% of cases. Our patient was a 45-year-old nulli gravida female. Her chief complaints were abdominal pain, abdominal pressure, dyspareunia, and a 4-month history of heavier periods. Her past medical and surgical history were unremarkable. She did have a pertinent family history of a mother who died from ovarian cancer at the age of 71. Pertinent social history, she had a 30-pack-year history of smoking, methamphetamine use disorder, and would binge drink as well. Labs and imaging. Fortunately, all of the tumor markers that we evaluated were found to be in the normal range. Ultrasound showed an enlarged uterus, a thickened endometrium, and an enlarged left ovary with max dimension of 9.7 centimeters, and an enlarged right ovary with max dimension of 11.5 centimeters. So the procedure that we carried out was a total laparoscopic hysterectomy with bilateral salpingo-oophorectomy. And so surgically, normally what's done is the ovaries and the uterus and the fallopian tubes are evacuated through the vagina from the pelvic cavity. But in this case, they were all too large to do that, so we had to fragment them. Upon fragmenting the ovaries, we very quickly realized what we were dealing with, as please pardon this expression, copious amounts of sebaceous material oozed out of each ovary once we attempted to cut it up. Also, we noticed lots of tan brown colored hair, over 1 dozen teeth, and in both ovaries. The pathology report revealed that fortunately there was no endometrial, cervical, tubal, or ovarian malignancy, and it confirmed that these were ovarian dermoid cysts, which is another term for mature teratoma. Unfortunately, we were unable to acquire the surgical pictures at this time because we are currently waiting on the patient to provide written consent to include her pictures in this case study. She has provided verbal consent, and she is supposed to be going up to the clinic this week to provide the written consent. So in the meantime, we've included some representative pictures of mature teratomas below. You can see on the left, we have one with a lot of teeth evident, and in the middle, a lot of hair, and then on the right, also some hair and some sebaceous fluid. You can see sebaceous fluid in all three of these, really. So in conclusion, this makes us think about the mother's ovarian cancer and what type it was, and whether or not maybe hers started as a mature teratoma which underwent malignant transformation, and then she inherited that form of teratoma to her daughter. Well, this is unlikely to be the case. Malignant, first of all, the chance of malignant transformation from a mature teratoma is pretty low. It's about 1%. And also familial or heritable ovarian teratomas are thought to be extremely rare. And then finally, the patient's social history does beg some questions. It's thought that long-term exposure to carcinogenic substances does increase one's risk of having a mature ovarian teratoma undergo malignant transformation. So it makes one wonder if this would have eventually happened had surgery not been pursued at this time. Thank you.